Our first speaker for the day is Dr. Sathish Kumar.
Stroke day. So you previously thought why these days are catching up. So neurologists, we always follow cardiologists. So when they do thrombolysis, then we do thrombolysis. When they do stenting, now we started doing stenting. But heart behaves easier to manage for the cardiologist, like they can do all plumbing work. But stroke is not as easy because you have one complications in the brain, not only the stroke. By doing all interventions, you can do harm to the patient by giving a bleed into the brain. So neurologists are very skeptical in managing stroke in a very aggressive manner. But time all the days we are gone. In neurology, in medical forum, we might have been learned neurology is a very boring subject. They will keep on discussing about what is there in a neurology. It's all about localizing where is the problem. Suppose the problem lies in the brain or in the brain stem or in the spinal cord, whether it is in the nerve root or in the nerve or in the neuromuscular junction or muscle. You don't know, because a foot drop can be because of a muscle or a nerve or a spinal cord or within the brain itself. So it's very tough. You can't keep repeating MRI brain, MRI spine, MRI of each and every time. So clinical knowledge is important, but nothing can be done once the patient is being diagnosed. So they keep on discussing where is the localization, where is the lesion, and after that they will discharge the patient with the same disability. So if people here, those practicing medicine in those eras before 1996, when the first ever time this drug was launched, when a stroke comes, till the time of 10 days after the discharge time, the patient will be on the Ryle's tube or in the Foley's catheter with a hemiparetic arm, discharged in a wheelchair, and the patient sometimes may not get discharged, may get disability or a death. So there is a paradigm shift now. Is brain, as told by Dr. Kumar Satya, time is muscle for heart attack, time is brain for acute stroke. So that's the basic concept of this new adage called time is brain is the window period in the management of acute ischemic stroke. We launched an acute stroke team in Fortis Malhar. We call it as FAST team, which is Fortis Acute Stroke Team. So with the help of, we are lucky to bring our Indian stroke president Dr. Dheeraj Khurana from Chandigarh on that day to launch. This is our whole gamut of neurologists and neurosurgeons here in our Fortis team. We have Dr. Dinesh Naik, who is our HOD here. This is our Indian stroke president. It's me, Dr. Iyer, Dr. Soundapan, who is the neurosurgeon for stroke, Dr. Suresh, neurologist, he is an emergency physician, Dr. Vikas Agarwal, a neurologist. So stroke is not led by a single person, it is a team of doctors, because you have to be 24/7 on the heels for a continuum of care. So whether it is the emergency personnel or the critical care or the neurosurgeon or the neurologist or the radiologist or the pathologist who does reports of PTINR on the time. So it's a management of a complete system of care by the stroke team. This is again on the launch of World Stroke Center on May 17, 2015, and the media coverage following the launch of this. So why this hospital gets a comprehensive stroke unit is important. This is the first center in Tamil Nadu, in Chennai, to get an American Heart Association accredited points for acute stroke management. To start with, we have launched, and following we have 4 more hospitals in Chennai launched following us. One is the Global Hospitals and Kaveri Hospitals, as well as in Balaji Medical College and Vijay Hospitals. So this is all our stroke member, whether it is a stroke nurse or the stroke coordinator or the stroke physician or the stroke neurologist, neurosurgeon, we will always form one single protocol. Whether I am available on station or not, the same protocol is followed throughout whenever the patient reaches on time. The protocol is a time-based protocol. So first 1 hour the patient comes, next 1 hour the patient comes, next 3rd hour patient comes. What is the protocol? And each and every patient, every team member applies the same stroke objective way of measuring. I will tell what is those measuring, because people call it as minor stroke improved, people call it as major stroke not improved, disabled. So there is no intra-observer variation in managing strokes. So there is a accredited stroke care program, and which has to be followed strictly. And this stroke center includes the physiotherapy, rehabilitation, how do you assess swallowing in the acute stroke. So all these points are taken care, and we form online exams to all the doctors in our team has completed, and we got accreditation from American Heart Association, accredited comprehensive stroke center, the first hour in Tamil Nadu and first hour in Chennai. So this is the launch on World Stroke and the PDF press coverage, following which then we are kind enough to have our Indian stroke president. We are going to have an stroke World Stroke Conference is going to held in Hyderabad on 25th to 29th, following which these happenings are happening. So we know, is it important like a heart attack? Yes, it is important. So the majority of strokes, you see India is in the top 5 countries of the incidence of stroke. So 69% of strokes occur in low and middle income countries like India, and there are various. So second leading cause of death after heart disease, it has surpassed cancer of the leading cause of death. So first is heart attack, second is stroke, third is the cancer. In November 2014, it has surpassed cancer as a serial killer disease. It is the most common cause of disability worldwide than heart attack. It's not orthopedic, it's not trauma, it is the most severe cause of disability. And having said that, in India it's a 1 decade earlier. So we are getting strokes in the ages of 30s and 40s, sudden strokes and new recurrent strokes incidents. Each and every 5 seconds someone somewhere is getting strokes. And in Chennai, as I told you, 200 to 3000 approximate stroke incidents, but only 20 came on time, and these people have been thrombolized. So there is a huge treatment gap. So this is the incidence of 41% of patients having had a stroke did not survive. So it's important, high mortality during the strokes. So this is important, and this is 64 life years are lost due to disability. So these are all the important points. This may be a numbers, but it is important point to the patient's lives. And India, the incidence is more common than in Western countries, than Australia and Europe and America. So the incidence is more in India and China. So the prevalence rate varies, and 12% of strokes in India are less than 40 years of age group. So this is the most crippling disease in young, and 40 years is not the age, because the life starts at the ages of 40. So it's a huge economic impact to the society, family as well as to the nation. So I told you, every 6 seconds strokes kill someone. Every other second somebody gets a stroke regardless of age. Female gets more strokes than male. This is the incidence in the worldwide. 33 million people have disabilities, and these numbers are real lives. So the incidence of risk of stroke is 1 in 5 women and 1 in 6 men. So incidence is very high in India, and it is most common. How do you identify a risk? Are every one of us are at the risk of stroke? So is there any stroke risk scorecard to identify to screen these populations? And each and every year during this month of October and November, we screen all our stroke package program, just like a master health checkup. We have a stroke package program to identify all the risk factors, educate, warn and treat and primarily prevent strokes in all our population. So this is the risk factors is a huge list. The most important thing, we can't do anything about the non-modifiable risk factors, because you can't reverse age, you can't reverse gender, you can't reverse race, and the family history of stroke, heart attack, TIA is a risk factor for stroke. The most important thing we have to be concentrating about primary prevention is this lifestyle related risk factors like obesity, metabolic syndrome, smoking, sedentary lifestyle is a risk factor for stroke, and the diet of course. And other modifiable risk factors like diabetes, hypertension, cardiac disease, each and everything is contributing to the stroke, exactly like a heart attack. This is a stroke risk card. If you have more and more risk factors, it will be as high risk on the red, low risk is in the green, and in between yellow is caution. So you should be very careful if you have this stroke risk card. So we all know, as a medical fraternity, there are 2 types of stroke. Unlike heart attack is a myocardial infarction, there is no myocardial hemorrhage. But there are 2 types. The most common is this ischemic stroke to the tune of 85%. And when there is a rupture of blood due to hypertension or aneurysm or trauma, it is called brain hemorrhage. The types of stroke, most common is ischemic stroke, almost 12 to 20% is hemorrhagic stroke. You see here, the most important thing in the management of stroke is not only diagnosed with a CT scan and MRI of, oh, this is ischemic stroke, this is hemorrhagic stroke. The most important thing is you have to identify what is the mechanism of stroke. I call it as MOS. So mechanism of stroke is important, because that's why you can prevent a second stroke, that's why you can prevent a primary stroke in the family. So whenever the patient gets discharged or followed up, so I will not be comfortable, I will be restless if I don't know what is the cause of stroke. So having said that, so this is a study in 2006 in Circulation where they told 1 month after the discharge or 1 year after the discharge follow-up, 30% of strokes, the mechanism of stroke is not known, even with all the medical facilities and all the recent trends in DSA, angiogram, everything available. That means we don't know the risk factor, we don't know the mechanism of strokes. So cardioembolic stroke, small vessel lacunar stroke is more common in India than large vessel atherosclerosis. And India, as compared to US and UK, we have double problems. One is the intracranial atherosclerosis as well as carotid atherosclerosis. So we have dual insults than large vessel atherosclerosis only in Western population. So Indian population, even if there is a carotid atherosclerosis, you can do stenting, you can prevent a stroke. But in India, you have both intracranial and extracranial, so you can't do stenting for intracranial atherosclerosis. That's why you can't prevent a stroke in India. So how do you identify a stroke? So the most important thing, chest pain, everybody knows of heart attack, but there is a mnemonic called, you spot a stroke by knowing what is FAST. F stands for face, A stands for arm, S stands for speech. If you identify one of these three symptoms, some major symptoms and signs of stroke, so this is the one we can educate to the public. We call it as FAST, which is ask the patient to smile, ask the patient to say E if the face droops on one side, which is the most important symptom and sign of stroke. Ask the patient to raise both arms, ask the patient to raise both the leg. If the one arm is weak or one arm is lifted and drooping slowly, so it may be a stroke. So this can happen anywhere while somebody is speaking like me in the podium, or somebody sitting in the public gathering. If somebody couldn't speak also, so the speech can be of two types. One is called a dysarthria, where there is a pronunciation is lost because of either facial palsy or because of cranial palsy. The most other thing is sometimes the patient may not understand the speech and they may not speak a single word at all. So that is called an aphasia. Aphasia is a language problem. The patient is not able to comprehend or express speech. That's itself again the language area of the stroke, brain is involved, so that is a stroke. So if you have a facial paralysis or arm or leg weakness or numbness, then if there is a speech problem, these are the three major synchronous findings of a stroke. So you should not afford to miss this, because stroke is a medical emergency. So if there is one or among combination of three symptoms, then the most important concept is T for time. You have to call a nearest stroke center ambulance. This 911 is not here, it is for American Stroke Association. So you have to call the nearest stroke center, because these patients' lives can be saved. But doesn't means that you should know that stroke can happen at any age, even from in utero to any point of time. So in India, the study conducted which shows stroke is more common in the young. You see here the most important risk factors are the smoking, illicit drug use. Recently we have a movie from Punjab side where drug usage is more common and they have a lift ban there. And pregnancy and puerperium is the risk of stroke. Oral contraceptives have the risk of stroke. Hypertension, dyslipidemia, diabetes, everybody knows it is a risk of stroke. So these are all rising in young in India, and that's why we are getting more and more strokes in young in India. The most important thing you have to identify in stroke in young is a dissection. So whenever there is a trauma, whenever there is manipulation of neck because of spondylitis or some massage centers, people come to a physician or a medical fraternity for symptoms of stroke. You have to rule out a dissection, because it is always hidden. Unless you do a carotid Doppler, unless you do an angiogram, you are not able to pick up dissection, and sometimes it is a painful neck vessels. So these are all the important risk factors of stroke in young. I have told you it kills more common than breast cancer. So everybody talk about breast cancer. It is 2 times killer disease than breast cancer, and you see here 1 in 6 women has a risk of stroke. 1 in 6 men has a risk of stroke, 1 in 5 women, but the mortality is more in women. So there is more incidence and more mortality in women than then. This is exactly opposite in heart attack in the premenopausal age group. Of course, the postmenopausal age group, the risk are the same. And in women, it is the more incidence, because they carry an extra risk factors, like they have to go through the process of pregnancy and preeclampsia, birth control pills, it's very common nowadays. Hormone replacement therapy because of PCOD is more common nowadays. Migraine in RA is undiagnosed, untreated, and if they have a risk of lifestyle factors like smoking in female, the risk is double and triple, and atrial fibrillation is more common in female than men. So how do you prevent a stroke? Is there any point we are talking about, strokes are more common, stroke is a serious killer disease, is the most common disability, and young strokes are common. How do you prevent a stroke? So you can prevent a stroke, identify the risk factor, and the most important thing is the primary prevention and the secondary prevention. Primary prevention is before getting a stroke, and secondary prevention is having a stroke. The incidence of secondary TIA and stroke is more than to the tune of 40%. The most important primary prevention strategies are this diagram, where you get active, do not be sedentary lifestyle, control your diet, control your cholesterol, eat better, check for blood pressure, lose weight, reduce sugar at all, and stop smoking. So if you adopt these at least basic lifestyles, we can prevent heart attack and stroke. Then if you had a stroke, what will you do? So then the concept of time here, so that is hyperactive stroke management, you should act fast. So if there is a mnemonic called fast to identify a stroke, once you identify a stroke, you have to act fast to reach the nearest stroke center. In Fortis, we call act fast because we run a Fortis acute stroke team. So the basic concept of management of stroke lies in this important diagram called ischemic core and the penumbra. The ischemic core is the one where the blood vessel is occluded. Surrounding the blood vessel, there is no lack of blood flow and oxygen, and that tissue is destined to die. Even whatever intervention or whatever treatment you give, that core tissue will not survive. But surrounding the ischemic core is the most important tissue called ischemic penumbra, where all the pathophysiology of stroke and its management lies. So this is called a salvageable brain tissue. So if the patient reaches on stroke center and you do intervention or you do thrombolysis on time within the window period of 4.5 hours, you can reduce the ischemic penumbra so that the final infarct volume will be only the core. But if you don't treat on time, the patient comes to the hospital after 4 hours, the patient start taking antiplatelets and physiotherapy after 4 hours, then the volume of infarct keep on increasing. Not only the penumbra, the penumbra also keeps increasing. So the whole brain, the hemisphere may get damaged. So the concept of time is the management of salvageable brain tissue called the penumbra. Why this is important? You see here, this is the brain tissue destined to die. So once you do a proper treatment called reperfusion, recanalization, you will have a volume of infarct, but it will not be as large as the original one at the time of stroke. But why this time is important? An untreated patient loses approximately 1.9 million neurons every minute after stroke. So this is the time factor which is important after the stroke. Once the blood flow is occluded, each and every minute 1.9 million neurons keep losing, and henceforth so on. And by doing acute window treatment, you can reperfuse, you can recanalize, so that the final volume of stroke can be reduced and the ultimate disability, ultimate quality of life after the stroke will be preserved. You see here, this is per second 32,000 million neurons die, per minute 1.9 million neurons die, per hour 120 million nerve cells keep dying, and per stroke you lost approximately 1.2 billion nerve cells. And how it converts into our life, we are talking about only numbers, let it die, we don't know because we are not doing quantification of how many nerve cells are dying. But you see here, per second after a stroke you age by 8.7 hours, and per minute after a stroke, suppose you have a stroke at the age of 10 a.m. and you don't reach within 1 hour of stroke center, you will keep aging by 3.1 week, and per hour you age by 3.6 years, and per stroke you age by 36 years. So if the patient doesn't reach on time within the window period of 4.5 hours to the stroke center, a 50 aged male or a female will behave like a 86-year-old male or a gentleman. So that means the importance of acute stroke management in time. So heart attack don't behave like this, because the patient will go back to the work, will talk, will go to the social gathering, but these stroke patients will be on the wheelchair, so they will be aged extra 36 more years. So this is the most common disability, and not only the disability, the time is more important here. So with a stroke, a time lost is a brain loss. So we all know that there is a window period and we have to reach the patient on time. So this slide says, if you reach the patient in the golden hour, there is a more chance of 30% better outcome than you bypass non-thrombolysis hospital. So I have told you there are 4 accredited stroke centers in Chennai, and there are so many hospitals, so many nursing homes, so many practitioners in and around in Chennai, and there are so many people can develop stroke each and every 2 seconds. So if they don't know when to refer and where to refer, and they don't, suppose the patient comes within half an hour of stroke and the patient doesn't go to the nearest stroke center, get this treatment, and that patient can go for medico-legal suing of the same physician or the practitioner. You haven't referred me to the stroke center, you haven't told me about the concept of stroke care which is available in this era, and this is a medico-legal problem happening in India as well as UK also. So thrombolysis in India, you see here, there are 100 centers are doing this routine TPA, which is only a systemic IV drug just like streptokinase, but there are 35 dedicated stroke centers like Fortis. 55 centers are capable of doing all these mechanical devices, but still there is delay in reaching the hospital, there is lack of awareness to the public, and there has to be a time to change, and there should be a paradigm shift. This concept of golden hour is this first 60 minutes of the stroke. Whenever the stroke patient reaches the ER, the first 1 hour, the first 10 minutes is the role of emergency physician. He has to triage whether it is a upper GA bleed, whether trauma, or it is a stroke. If it is a stroke, he has to give an importance than any other condition except heart attack. So heart attack and stroke in emergency is important. So we have to inform the stroke team, which includes the stroke physician and the stroke neurologist and all the stroke team what I told, whether it is a stroke nurse, radiologist, radiographer, because each and everywhere time is important. You have to finish each and the whole line of sequence of investigation, because without CT scan you cannot thrombolyze, because CT scan is the basic thing to know whether it is an ischemic stroke or a hemorrhagic stroke. So 25 minutes you have to do a CT scan. So if you have a stroke and you refer to the nearest radiologist for a CT scan, the patient goes there, wait in the queue, get the CT scan, wait for the report, come back to the same practitioner or a medical fraternity, and almost 4 hours is already lost, and then after the report it is a stroke, or sometimes CT scan can be normal in the first 48 hours of stroke, and everybody will be worrying whether we are dealing with stroke or something else. So that's why the time is lost everywhere. So if there is any symptoms of facial, arm or speech disturbances, this patient has to be nearest to the stroke center where there is in-house facility of a stroke neurologist and a CT scan within the same roof. So if the patient in the same hospital is sending a CT scan outside and waiting for the CT report, that means it is not a stroke center. So the basic quality should be a neurologist and a CT scan within the hospital, and within the first 60 minutes we call it as door to needle time. Door is the onset of stroke and the patient comes to the emergency to the hospital, and needle is the tissue drug what we are giving, which is recombinant tissue plasminogen activator. We call it as TPA, Altiplase, which is the only drug approved worldwide from 1996 to 2016 till now, and there are no other drugs. Like cardiologists, they are using streptokinase, they are using Altiplase, they are using tenecteplase, each and everything is approved, but India only Altiplase is approved. Streptokinase produces more bleed than Altiplase, tenecteplase produces more intracranial bleed than Altiplase. So only drug worldwide approved and standard of care treatment for stroke is this TPA. So if you have a CT scan with this hyperdense white finding, it is a bleed, it is not ischemic stroke, so it is a brain hemorrhage, then we are not talking about what is the golden hour in this management. So this is not a TPA candidate. These are all what I talk about accredited stroke center, where you have to form a plan, a written plan, because each and everybody has to follow the same plan. We call it as ASA plan, acute stroke action plan. This is so many things you have to document. So it's a team of people, a nurse, a paramedics, and everybody has to do simultaneous jobs. And these are all the stroke scales, objective way of scoring. Each and every component of neurology is enlightened here, and you have to score objectively, so that at baseline, at 8 hour, at 1 day, at 7 day, at 1 month, how much is the improvement in all these stroke scales. So a modified Rankin scale is the scale of disability. Barthel index is the scale of independence. Once after the stroke, how the patient improves in all these personal grooming, dressing, toilet use on independently. So these scores has to be scored, and everybody has to score appropriately, and that's where the certification and training is. And everybody has to get this certification from American Stroke Association, which is valid for 12 months. That is the most important thing, because each and every year you have to get updated. So what is the protocol you follow in there is a stroke? Any patient with acute neurological deficit which is very severe and sudden, we know it is a vascular and it can be a stroke, and it arrives in the ER, and the ER is the important key person to identify as a stroke. Sometimes there will be always a doubt whether the patient's speech or the patient weakness is due to stroke or something else, because if it is a non-stroke, time is there, whether I should involve, alert all the neurologists at midnight of 3 a.m. I have to call him, disturb him, he has to come all along from the to the hospital. So non-stroke is an emergency or not. But having said that, even if it is not a clear of stroke, if you think it is a non-stroke, we call it as a stroke mimic. Stroke mimic. Stroke mimic is also important because sometimes you overdo no harm, but you underdo, missing a condition for stroke mimic can be a real stroke, and there will be the real disability. What are the stroke mimics? The stroke mimics are hypoglycemia, stroke mimics are hyponatremia, sometimes a trivial fall with small subdural, extradural collections outside the brain can be a stroke mimic. The patient remember the fall, he comes one day with a weakness of one side, and you do a CT scan. Sometimes CT scan may be very difficult to identify a chronic subdural hemorrhage which behaves like a focal weakness. So it still itself is a stroke mimic. Hyponatremia I told, and post-stroke seizures. The patient had a seizure, the attendant doesn't give the history of seizure, and he have a Todd's palsy after the seizure. So it have a focal deficit. So all these conditions are called stroke mimic, but stroke mimic is safe to thrombolyze. So you don't need to waste your logic to understand whether we are dealing with stroke or stroke mimic. So any focal neurological deficit which is sudden, with a CT scan which is not hemorrhage, with a CT scan which can be normal in the first 48 hours of stroke, still it is a stroke, and you have to send to the nearest stroke center for thrombolysis. So if it is a stroke, it's a medical emergency, get an urgent CT scan, and you have to go for a huge checklist of what is the eligibility criteria. You can't use this drug very safely because there is always a bleed happen with this drug. So you have a huge relative and absolute contraindications, recent surgery, recent heart attack, recent trauma, serious bleed, all those things are contraindications. And these patients has to be admitted in a stroke center because each and every 15 minutes in the first 4 hours you have to monitor BP, heart rate, pupils, and sometimes these patients, the stroke keeps worsening and the patient will develop a severe cerebral edema and ICP, and there will be pupillar dilation, and these patients has to be taken care of. Intervention like mechanical devices, I will show you what are these, and sometimes to reduce the cerebral edema we have to do a procedure called a hemicraniectomy, which is a decompressive. This bone flap has to be removed to save the life. So monitoring is not easy in small centers, and the quality of care in the stroke care, because all the dedicated stroke assessment is done, and you can easily pick up complications as and when needed. And you have a huge list of thrombolysis follow-up. As I told you, this is BP management and all those things. This is the drug what I am talking about, is this Actylize, which is called the tissue plasminogen activator. Dose is 0.9 milligram per kilogram, and this is available in two strengths, 50 milligram and 20 milligram vial. Approximate cost will be almost like 45,000 for 50 milligram and 20,000 for 20 milligram. BP management, I will tell you, please do not use any drug to reduce BP in the acute stroke, because we may not know whether the BP of 150 is normal to the patient, 180 is normal to the patient, 190 is normal to the patient, because you just know about symptoms, you don't know about what is the vasculature. There can be a large vessel occlusion, you try to reduce the BP, thereby no blood flow to the vessel, to the brain, and ultimately the ischemic penumbra keeps increasing. Please do not do anything including sublingual depine or any oral antihypertensives or any injectable drugs to reduce BP in the acute stroke in the first 8 hours of stroke. Please send the patient without any aspirin, without any cloxane, without any drugs, not even any oral fluids or anything, because the patient can aspirate if you do any intervention. So aspirin is contraindicated in the first 24 hours of stroke care if you are thrombolyzing. So if you are given aspirin, we can thrombolyze because the patient bleed, and if you are given low molecular weight heparin or enoxaparin, then again we cannot do thrombolysis. So please do not do anything. Please call the nearest ambulance, refer to the stroke centers. So that is the only thing you should do if you know it is acute stroke. And don't reduce the BP, but you have to reduce the BP if the BP is more than 220 by 120 diastolic. So that is damaging the brain. So if the BP is too high, then again you can't do oral antihypertensive drugs. You have to just start nitroprusside or labetalol bolus, because nitroglycerin is contraindicated. If you do NTG or NTG patch or NTG infusion, there is cerebral vasodilatation and reversible steal phenomenon, and the ischemic penumbra keeps increasing, and you are doing more harm than doing the benefit. So this is one simple example of a 64-year-old male a resident of Kalambakam, which is 15 kilometers away from Adayar Fortis. He had 8:45 p.m. on this day. He had a facial asymmetry, right-sided weakness, and cannot able to speak and understand, and he is drowsy since then. So he goes to the nearest hospital called Chettinad Hospital in Kalambakam. From there, at the midnight, they know they can't do this acute stroke care. Then they have called us and referred to our Fortis Miller. So at midnight, around middle of the night, 30 a.m., he has reached our hospital. 8:45 he had a stroke, and by this time he went to the nearest physician. From the physician refers to Kalambakam Hospital, Chettinad Hospital. There they did a CT scan, identified stroke, and referred to Fortis Miller for some intervention. So whole gamut of time is wasted till now, and you hear the patient is completely okay, BP is okay, he had an atrial fibrillation, there is no carotid large vessel bruit, other system was normal except atrial fibrillation. He is completely drowsy. This is a GCS, aphasic, he cannot speak. The left side is working, right side is not working. His two pros is not responding to commands. Had a complete right side gaze palsy. If the eyes are not moving on both sides, eyes, whenever there is a large stroke, eye cannot look into the side of the stroke. That is a dictum. So there is a right side hemiparesis, the right cannot look towards the right side. So that means you are dealing with a larger stroke, and these patients will have more and more of morbidity and death, and these patients has to refer to the nearest stroke center. Facial palsy, aphasia, power is 3/5. So we know it is a large stroke. We know the diagnosis, it is possibly a left MCA infarct. The risk factor is smoker, alcoholic, and atrial fibrillation. This is a scan taken in Chettinad Hospital. They have reported as normal. It is completely normal within the first 3 hours of stroke, but you have to carefully look into the small, a thrombosed middle cerebral artery here and a thrombosed middle cerebral artery cut off there. So here in the ciliary fissure there is no thrombosis. So there is a left middle cerebral artery thrombosis here, and this is after this injection. Even then the patient has developed an infarct. So that why the patient has developed infarct? Because the patient hasn't reached time within the 1 hour. The patient reaches almost 3.5 hours of the stroke. But this is an occlusion here, complete cut off. But luckily this patient improved, recanalized even after 3.5 hours also. So he had a stroke at 8:45, reached our hospital at midnight. We examined in next 5 minutes. CT scan we didn't do because already it was done, and we given injection in the next 15 minutes. So the door to needle time is, ideally it should be 1 hour. From here it is very active because all our members are on the loop. We are already in the hospital and the patient reaches within the ambulance. So the patient has improved. So this is the drug we gave, 5 milligram bolus and 45 milligram infusion, and this is the stroke scale what I am talking. He had a very moribund stroke. More than 12 NIHS is critical to survive, and he had a very severe stroke. Within 1 hour he has improved dramatically. Within the first hour, 8 hours he became better, and within the first 1 month there is mild slurring of speech and has difficulty in pronouncing some names of objects. Otherwise he became completely normal. So he came in a wheelchair. Within the first 1 hour he started walking. This is the next 8 hours he became completely normal, and we didn't examine how he feeds, grooms and toilet in the first 8 hours, but within the first 8 hours he can able to attend all his activities of daily living slowly. So these are all the objective way of scoring a stroke, and for this stroke you can document all our stroke patients. We have done more than 80 thrombolysis in the last 5 years, and all data are enrolled online, and we can publish on the strokes. So Praveen, can you just click on this video, first one, above, first one, mela. Yes. So this is a video of the same patient on the day of thrombolysis. This is just 8 hours after thrombolysis. Midnight we thrombolyzed him around 1 o'clock, and the next day morning we called him to the OPD and we taken a video because we didn't do videograph on the photoshoot at the time of thrombolysis. Then he is completely normal. He can walk, he can speak, and the only deficit he has, he cannot name some names of people. So that is aphasia is still persisting. You know how he is from the hemiplegia he has completely improved. So the hemiplegia has completely improved. So he has a right-sided weakness, can able to speak well. Facial palsy, face palsy, speech, everything has improved.
Tip top. 55. Pardon me.
So what happened to you, ma'am? What
Had a
happened to you?
stroke.
You don't
Middle of
remember,
the
I
night.
suppose.
This is the
He came on
8 days after,
27th.
I think 7 days after thrombolysis. Complete similar right hemiplegia aphasia. He can speak in 6 different languages. He is a businessman. He is almost 44 and no risk factor except smoking. So he is the nephew
After
of
that,
Thomas film
before
star in
coming,
our city.
Before he came to the hospital, what was his
His
position?
daughter is a medical student. She knows the importance of medical TPA, and they claim that
Right
she
side
should
of the
come to
body
hospital
plus-
immediately. They live in Besant Nagar. They reach within 10 minutes. Within first 45
Everybody
minutes we
is
gave the
conscious
injection,
level and
but it doesn't work well to him because it is a large IC occlusion. At the age of 7 day after thrombolysis, still he is
And
under wheelchair.
after that injection,
But
is there
he
any
started.
improvement you noticed?
The first 7 days, though he could understand everything, he was not able to talk much. But,
Yeah.
After about 10 days, he was able to, once the words started coming, next 2-3 days, all his languages, he's quite fluent in many languages, they
Yeah.
are coming one after the other. Of course, he can speak for 8 words, but on the whole, he's
This is the same patient on the 3 months follow-up and the OPD. He can walk.
yes,
He had a
yes.
hemiplegia. Yes, I agree there is a hemiplegia. But this treatment has saved his life, saved many functions of his life. And now he is 3 years post follow-up now. And he is going to, beach walking in a very normal manner. So he started speaking very fluently.
Going for morning walk and all those things. Evening walk. About 15-20 minutes.
He speaks well. So he speaks Spanish, he speaks Italian, he
So
speaks
lift your hand.
English. So he's a businessman, he can speak well. So some amount of
Can you able to take food with that hand? No, I'm not trying.
just talk about class and
Yes, the 4 things I can do. I can take class. I can fit up it.
You can go to the PowerPoint. And there are so many videos we keep documenting because sometimes you have to show this video to make the patient understand this is not harmful, please go for this. Because we talk about in acute emergency setting, this drug costs 65,000 rupees and sometimes you can bleed brain and you have to go for surgery, people get scared. And these videos helps ourselves and helps patient to identify what we are talking in an emergency, hyperacute emergency settings, and they understand, okay, the doctor whatever he is showing is right only, we can take risk and go for thrombolysis. So there are, the guideline says, American guideline says, initially it was approved for 3 hours, now they extended up to 4.5 hours. The European Stroke Organization guidelines recommended within 4.5 hours. Our Indian Stroke Organization has recommended onset of stroke symptoms up to 4.5 hours. So this is the window period 4.5 hours, but 4.5 hours doesn't mean that you have to wait till 4.5 hours. So I told you each and every minute after a stroke 1.9 million nerve cells keep dying. So as soon as possible the patient comes to the hospital, because I have told two patients, the first patient within 30 minutes, the second patient 3.5 hours. Even though the outcome is paradox here, the patient who reaches late from Kelambakam has improved very well. The first patient which reaches immediately. It all depends upon the mechanism of stroke and mechanism of occlusion. So earlier the better outcome. But there are other procedures like intra-arterial thrombolysis, which we call it as local thrombolysis. We go directly to the vessel, identify the block, give the TPA and try to dissolve the clot, which you need a cath lab, which you need an intervention and other expertise to treat. Till up to 8 hours now we can do intervention. So the patient reaches you at 5 hours doesn't mean that the patient cannot be benefited. So up to 8 hours stroke management is possible. Posterior circulation stroke is very important because it is in the brainstem stroke. Each and every millimeter of tissue is important, which is responsible for breathing, circulation, heart activity, conscious level, walking, understanding. So if the posterior circulation is affected, we don't have any window period. There are people who do intervention up to 24 hours also, 72 hours also. It all depends upon how much area of viable tissue you are able to salvage. So you do MRI, you do perfusion, diffusion, mismatch, identify if the mismatch is big, then you do interventions. But having said, a large majority of patients in India do not get TPA because of lack of adequate facilities, lack of knowledge about stroke, lack of a proper referral and triage system in acute stroke care. So this is a device, can you click on the video? This is approved up to 8 hours of stroke. You can see there is a clot there. This is a coil shaped device which goes there, engulf the clot and come back. So this is a distal protection balloon so that there is no ongoing shower of embolus to the distal part of the brain. Next slide. This is approved. This is all available in India now. This is a penumbra device. So this is again just like acts like a vacuum cleaner. It sucks the clot slowly. So there is a clot sitting there, and if it doesn't improve by IV TPA, like the patient doesn't mix better, then next you shift the patient to the cath lab, identify the clot, put the catheter, reach the vessel, and try to do either the Mercy device or the penumbra device. Now we have the third device which is approved called Salter device. So these devices are little costlier. It is not only 65,000. So it may cost sometimes 1.5 lakhs extra to the patient, but many times just like heart attack, stroke is also important. So there is never, it is cost effective in many centers. But in our center, we have keep on doing thrombolysis, all these interventions. So we keep missing patients because of lack of money. The people worry about corporate hospital. People worry about, I didn't carry my credit card, ATM card on the day of middle of the night. So we lose patients because they tell us, doctor, I don't have money to pay to advance to do all these procedures. So I go back to the financial planning, sitting with them. I told, please don't ask patients to pay money on the time of stroke because nobody carry money of 1 lakh or whatever. See, so you admit the patient, let the patient get the benefit of taking TPA, taking whatever, get the consent, and then come back tomorrow. If the patient is in the hospital only, they pay the first 24 hours of stay, including ICA, including ventilator, including all this drug which costs 60,000, including CT angio which costs 18,000, and all the package of blood labs is 1 lakh per day. So which ideally it should be more than 1.4 lakhs per day, because we are running a comprehensive stroke center. We asked our financial admin to reduce our package so that all the patient comes and pay just only 5,000 rupees, get admitted. At the time of discharge, the 1 day package is 1 lakh. And many times the patient got improved, better discharge on the same day. Many times the patient go to the nearest GCATs, nearest nursing centers which refer the patient, and they just pay 1 lakh and get all the treatment adequate facilities, including scan, everything. We don't do MRI in all the patients, only in selected cases. So there are lots and lots of points to be told about stroke. We will take it in the questions. So I conclude, time is brain because brain matters a lot. So I call time is brain and brain is money. Thank you.
Sir, actually, most of our patients are on aspirin for cardiac illness.
Yes.
Is it a contraindication for giving thrombolysis?
No. Aspirin as well as dual antiplatelets or even warfarin is not a contraindication for thrombolysis.
If they are on the day
if they are already on even on the day of the stroke. So, but one thing you have to ask is in the questionnaire, screening questionnaire, whether they are on any antiplatelets or anticoagulants, but everybody will be on, almost 40% of population on diabetes. So if so, then you have to ask for PT-INR. If INR is more than 1.7, INR, more than 1.7 is a contraindication. You should not thrombolyze.
Okay. Before sending the patient to you for management, what is the first aid treatment you have to give as a local practitioner or as a local doctor? First aid treatment for
First aid treatment, ideally I will tell you just warn the patient to go without taking anything. That's the best thing you as a practitioner, as a stroke, stroke hero or a stroke supporter should do. So don't give any drugs.
Mannitol or
Nothing.
hydration,
No. Maybe you can start IV fluids or NS, but don't waste time anywhere. That's a key concept.
Thank you.
Active fibrillation, that is by irregular pulse and all are known to have, and then develops stroke, then we can straight away give aspirin also. It's your duty, ischemic stroke only.
All ischemic strokes should be given if I am not thrombolizing. Suppose the patient comes to you and it's a minor stroke and you decided you are not thrombolizing or out of the window period, then the treatment carries whole as per the practice. So aspirin is good enough, even aspirin with combination or even anticoagulation is there. But if you are thinking within the window period, within the window period is a 4.5 hours of stroke, you don't know how the patient going to behave next 1 hour, next 15 minutes, next day, because you may lose the patient thinking that it is a stroke in evolution. So then those patients, you tell them that there is a treatment available, this is the only approved treatment worldwide for first 4.5 hours or sometimes extended up to 8 hours. If they are not willing and if they want to make sure that they want to continue the routine conservative approach, document them in the file, then give on antiplatelets and whatever thing is as per the guidelines. 24 hours after thrombolysis we will start antiplatelets. The first 24 hours after thrombolysis you should not supposed to give even any IM prick, Ryle's tube, Foley. So ideally you should have a protocol. If there is a moribund patient cannot able to take drugs, then you have to put Ryle's tube and Foley simultaneously when the drug is going on, because the bolus is given on the CT scan room itself. The next 1 hour is a luxury for next other 1 hour of infusion is going on. By this time simultaneously you do all Ryle's tube and Foley's. Do not do anything in the first 6 hours after the IV thrombolysis, not even ABG, not even puncture, because it is a systemic thrombolysis, it will produce ooze.
Sir, you said about ICA occlusion. Why not going for a CEA?
Yes, it's a very good question. For large carotid things you should see. I am just talking about tip of the iceberg. I will just talk about CT scan. Ideally speaking, stroke center, stroke unit should do is CT and CT angio. So but don't wait for CT angio, because you are wasting time in interpretation, waiting for the radiologist to come and see what is their occlusion and all. As per the Indian stroke guidelines, world stroke guidelines say CT scan is enough to thrombolyze, but I didn't stop there. I want to know what is the mechanism of stroke. So for mechanism of stroke, you have to definitely do which pipe is occluded. Whether it is basilar or anterior, or if there is a large occlusion, then IV thrombolysis will not help in many patients. So IV thrombolysis alone will not help in many patients. That's why I told the story of two patients. For examples, one large vessel occlusion, you need to do interventions. So interventions include whatever the device we thought. Just suck the device with even a small syringe, go to the carotid or into the intracranial, just stop sucking slowly, then acute thrombus vessel plug will come out. If it is a large standing atherosclerosis, and if it is a long atherosclerosis from the heart to the from the neck to the brain, you can't do anything. Then you can't do bypass or you can't do endarterectomy. So don't do any stenting or intervention in the first 2 weeks of acute stroke. So ideally all secondary treatment protocol, prevention of recurrent strokes for stenting, carotid endarterectomy should be done immediately as soon as possible after 2 weeks of stroke.
The patient has got only transient
Ischemic attacks.
no stroke.
Yes.
Prior to stroke.
Yes. It's an atom bomb in the brain. So don't tell them lucky you improved and go home. No. So transient ischemic attack should be admitted. So there is a scoring scale called Chad-Vask scoring scale, that if it is a congestive heart failure, if it is if it is an age more than 75, blood pressure more than 180 by 100, if it is coronary artery disease or congestive heart failure, if it is diabetes, and if the MRI or CT scan everybody wants to do, everybody will do in a TAA. If it shows any infarct or small vessel changes or any large vessel occlusion, this patient should be admitted, because the chances of stroke in first every hour or every minute after TAA is high, to the tune of 17%. So TAA, don't be happy, but it is a danger signal. Should be
Everything is normal. The consciousness is there, everything, no evidence of any stroke, only TAA.
TAA.
And also you ask us to admit, sir.
no.
Otherwise it will-
See, if I told there is called ABCD3 score. If the score is more than 4, you have to admit. If it is less than 4, all stroke centers is burdened with stroke, so you tell them you go home, but you have to investigate with MRI brain, MR angiogram, lipid profile, all parameters, put them on dual antiplatelets and ask them to follow up on OPD. And all acute strokes TAA, dual antiplatelets for 3 months is advised nowadays.
Do you have any protocols for venous thrombosis?
Yes, sir. So venous thrombosis is very difficult to treat many times, depends upon the morbidity of the patient. So it happens previously called postpartum state, not necessarily postpartum, it can happen in young males, alcoholics, trauma can induce CVT, smoking can induce, OCPs can induce, migraine and oral contraceptive pills for PCOD can increase CVT. So always high index of suspicion in pregnancy whenever there is complaining of headache and focal symptoms. So unless you don't ask for venogram in CT or MRI, it is often missed. So then the patient keeps on, jumping to one other doctor, and at the end they will come to the emergency with a severe raised ICP and mortality. So management of CVT includes, it's a critical care unit. Don't take very lightly, because we don't know what is the extent of deep vein is occluded, because only venogram only shows the large superficial veins. If there is a deep vein occlusion, the mortality is 40%. So treatment is 3% saline, strict stroke care unit protocol, which gives better outcome. All patients, even if there is hemorrhage in the CT or MRI, should be given on anticoagulation. Thank you.
Is there any risk of plaques, cholesterol or protein or plaques getting destroyed?
Yes, sir. Yes. So the only approved treatment is IV. IV dissolves all clot like like a tsunami effect. So it from the vein, it goes to the heart, it goes to the brain, everywhere. So there is that's a chance of bleeding is always there. That is out of 1 in 3 will get 1 out of 100, 3 will get bleed. Other 97 will be benefited. So strokes, even if it happens, it's a systemic thrombolysis, it will improve. What we are talking about is the mechanical devices. When you put the patient on cath lab, go into the artery where it is occluded, stop doing plumbing work like cardiologists we do, there is a chance of bleed, rupture of vessel, as well as recurrent strokes. And that's why the newer devices are coming with a distal protection device that can capture like an umbrella. Is there any other plaque going forward also? So that's what the revolution is. So lots of work and research is going on in that.
For a routine ultrasound or some other investigation which is done, and we find out that the carotid artery has got stenosis, atherosclerosis or something. Beyond what will probably cause a stroke? Or do they have?
Correct. So see, it's an important question. What I want to raise concern about all the audiences here is a master health checkup. So master health checkup is only only investigating about heart, TMT, echo, ECG. That all. Nobody does carotid ultrasound. Nobody asks for Doppler. So all the risk factor is there in all the patient of heart attack. So as I enlisted, age is there, blood pressure is there, diabetes is there, more prevalent, smoking, alcoholism, obesity, sedentary lifestyle. So each and every patient after the ages of 40, it can start with 30s also. So if you screen them, the population of, we have done a study in Chandigarh where we have started population from the age of 30 and 50 a day, screening ultrasound in all the patients. We do screening on our own hands. So that shows a percentage of less than 50% of population, 75% of young healthy adults have carotid atherosclerosis up to 40%. Up to 50%, don't worry, you don't need to treat them, you don't need to give even statins, even on antiplatelets also, because you do more harm than benefit, long-term treatment. But more than 50% stenosis, best medical treatment, whether you give statins, antiplatelets, is enough. More than 70% to 99%, then lies the role of stenting and endarterectomy. Depends upon whether it is amenable to stenting. Suppose if it is a large lesion from arch of aorta to the brain, you can't stent them. If it is a large lesion where you can't go and remove the plug, so carotid endarterectomy is only for certain population where there is a small plaque in the origin of the vessel. If it is a long vessel, you can't do anything. There are Indian populations, 50% of Indian populations have long-standing atherosclerosis of long vessels. Like, from the origin till the intracranial vessels is occluded. So God only saves them because there is a very good collateral of posterior circulation, PCA and other things. So intervention is only needed only if you do in a center where the complication rates are less. So don't put them, there is a plaque, don't tell them you need to get stented, you need to get bypassed and all those things. So refer to a stroke physician. He will decide whether this patient needs to be stented, needs to be endarterectomy. Otherwise, just give best medical therapy which heals, cures more than 70% of populations.
Also tell about the campaign. So this month
yeah, we are doing a primary as well as secondary stroke prevention campaign, which is a very 50% of rates for CT angio, 50% of rates for carotid ultrasound, including all the basic screening of echo, ECG, lipid profile, which includes all the master kill checkups. For every month of October 29 to November 29. This month we are starting from October 29th onwards to November 29th on the commemoration of World Stroke Day. Last year also we have screened I think more than 100 populations, 102 patients last month also. And those patients are still following with us. They are happy that we have done anything better than them. So that is there. And almost many stroke centers are doing it like this. Thank you.